Dr. Yogeswaran Lokanathan from University of Kebangsaan, Malaysia, Kuala Lumpur. And Dr. Yogeswaran is a senior lecturer at the Department of Tissue Engineering and Regenerative Medicine, Faculty of Medicine, National University of Malaysia. His research focuses on peripheral nerve and spinal cord regeneration using cellular therapies, biomaterials, and tissue engineering approaches, with an emphasis on cell secretome analysis and scaffold fabrication. Dr. Yogeswaran currently serves as Deputy President of the Tissue Engineering and Regenerative Medicine Society of Malaysia. Today, he'll be talking to us about the potential of Wharton jelly-derived mesenchymal cells, derived small extracellular vesicles in managing metabolic syndrome in an animal model. Over to you.
A very good afternoon to all the delegates, and thank you to the chairperson for the kind introduction. And also thank you very much to the CMC and the organizing team for the opportunity to be here, and also for the warm hospitality. So my title here, Potential of Wharton Jelly MSc, WMSc, for small extracellular vesicle, in short SEV, in managing metabolic syndrome. So my topic will be slightly different from what we have heard from the morning. So Ilaraja Krishnan was the PhD student, and this study involved many other students and also co-investigators. So I'm basically from Department of Tissue Engineering and Regenerative Medicine, National University of Malaysia. So a quick introduction. So what is metabolic syndrome? So metabolic syndrome is cluster of at least 3 of the 5 conditions below. First is elevated waist circumference, which is defined by the population and country. So for example, USA 102 cm, for Asian is 19 cm for male, and for women is 80. So different cutoff for different country and population, and male and female. For hypertension, more than 130 or 85 milligram mercury. Hyperglycemia, more than 100 milligram DL. Low hypodiplomia, and so hypertriglycemia. So when we have more than this cutoff point, it's 3 of these 5 conditions is considered we are having metabolic syndrome. So we can see the global prevalence of MS. So there's various different definition, and when we see the JIS definition, we can see 46% of American population is classified as having metabolic syndrome, and rest of the world is considered more than 25 and even 30 of the population. 1 in 3 or 1 in 2 is considered having metabolic syndrome, basically all over the world. And comorbidity, the diseases that coexist, actually is like extensive, and almost like various conditions can coexist with metabolic syndrome, such as heart disease, joint problems, hypertension, insulin resistance, PCOS, memory loss, GERD, respiratory syndrome, inflammatory disease, and also some neurodegenerative diseases is known to coexist with either induce or coexist with MS. So risk factors, first is genetic background. Besides genetic, the unhealthy lifestyle, such as smoking, Western dietary patterns, physical inactivity, alcohol consumption, sugary and soft drink consumption. So besides that, low socioeconomic status and also post-menopausal status also can contribute to metabolic syndrome. So current treatment, I think today morning also we see this, there's no single treatment to cover all the elements of MS. We are currently treating single symptoms with one drug. So it's called polypharmacy approaches, multiple drug targeting multiple element of MS. So the for non-pharmacological approach, basically is to reduce the diet and calorie intake, increase exercise, quit smoking, reduce alcohol consumption, basically having a good or a healthy lifestyle. So the challenges with the polypharmacy, compliance issue, because there's a various drug need to be taken at various time point, drug interaction, and adverse reaction or side effect of drugs, and also relapse after taking this medication for some time. So we need to look for alternative treatment that can not only treat the symptom, but can target the root cause of MS and also restore the normal homeostasis and repairing function of our body. So previous studies are shown that MSC and MSC-derived extracellular vesicle can alleviate various symptoms of MS, such as diabetes, hypertension, various other clusters, but there's no study that study the effect of EV on metabolic syndrome as a whole. So this is one of the first study that study the effect of MET-S with the effect of extracellular vesicle from MSCs. So how the MSC or MSC-derived EV act on metabolic syndrome through immunomodulation, anti-inflammatory effect, and also restore the cytokine homeostasis. So the mechanism, it increased the IL-10 and adiponectin, which in turn reduce the inflammation and also reduce the insulin resistance. It also can correct the cellular dysfunction and elevate MET-S. So, most of our studies in our center is more to translationary basis. So we want to validate the MSC-derived EVs by preclinical validation for quality, safety, and efficacy. And once this phase is conducted, we can move on to the regulatory approval phase, which is first will be clinical trial. So the research question of this study is whether delivery of allogenic WJMSC exosome or SEVs by IV intravenous injection is safe and efficacious as treatment of various disorders associated with metabolic syndrome in rat model. So study objective to evaluate the effect of WJMSC SEVs preparation IV injection in managing MET-S rat models. So first objective is to isolate, concentrate, and characterize the SEVs in vitro. Second, to evaluate the quality control parameters to standardize the human fetal MSC. So as I mentioned, to move towards regulatory approval, we need to standardize the SEVs because it's known that the exosome or MSC is isolated from human sample have various, batch variation. So we need to come up with the methods to standardize these EV preparations. So then we move to the safety, whether this EV when injected to this rat model, is it safe in the rat model? And finally, in the MET-S model, whether the SEVs can elevate the MET-S. So for the first objective and first and second objective, basically we isolated umbilical cord from 4 donors and characterized them according to the international stem cell guidelines. We passage them up to passage 3, then follow the ISCT guideline. First, stochastic adherence and morphology observation. Second, to look at the WJMSC surface markers or CD markers by flow cytometry, and then by 3 lineage differentiation. Thereafter, we isolate the EV from condition medium at passage 3, then characterize them according to the international guideline on SEVs, which is MySEF 2018. So basically, we isolated the SEVs from the condition medium using tangential flow filtration method, and then same for isolated SEVs was characterized separately. We didn't pool them. We isolate and characterize them individually by BCA assay, nanoparticle tracking analysis, EV protein marker analysis, and also the morphology by TEM. So for the first objective, we can see the EV preparation having the CD63 and TSG101, which are the positive markers for exosome. Albumin, which is the purity marker, shows there's a lot of albumin in the EV prep that we isolated, and GRP94, which is the negative marker for exosome, only present in the cell lysate and not present in the 4 EV isolates. And TM images show there's EV preparation having the bilayer lipid membrane particle. So we can see the 4 EV isolates having a different number of particles, and EV3 have the highest particles. And we check, as I mentioned, the purity determination. When the cells have less than 1.5 billion particles per microgram, it's considered unpure. So our preparation is considered unpure, but previous studies have shown that the albumin and other co-isolates cannot be totally separated from the exosome because these also participate in the signaling or the effect of the SEVs. So basically for the quality study conclusion, we have successfully isolated, concentrated, characterized the MSC-derived EVs, and they are size less than 200 nanometer, albumin detected, and production intensity was only observed in protein concentration. And finally, a number of particles was chosen as dosing for the safety and the further particles, because when we use the protein concentration, it's mainly because the albumin. So we can't use the protein concentration. So we decided to use the number of particles based on the NTA analysis. So for the second part, we used the healthy Sprague Dolly rats, 8 weeks old. Then we acclimatized for 2 weeks, and we just have 2 groups, control group which is treated with the normal saline, and then the high dose group which is treated with the 9 billion SCVs particles. And we observe them for 90 days. We using multiple daily observation for morbidity and mortality, physical measurements, full blood count, selected serum biochemistry, necropsy at day 14 for acute phase safety, and also day 90 for subchronic safety profile. Besides that, we also track the injected SCVs using PKH26 label SCVs, and we sacrifice the rats after 24 hours and check the lung, liver, and spleen and also kidney for the PKH26 labels SCV presence on these tissues. So basically, we don't see much difference in the physical measurements, hematology, and biochemistry, especially at the end of the 12 weeks safety profile, safety studies. In the necropsy, only liver shows there's some reduction in the relative weight. And also in the, we can see here like the control as the moderate chronic toxicity, whereas in the treated there's a mild toxicity. For the lung, even the untreated lung tissue shows some severe inflammation, wherever in the treated it shows there's no lung inflammation. Okay, I'll move on. So for the biodistribution, we can see the presence of the SCVs in the lung, liver, and also spleen, and most of the SCVs was found in the spleen. First, for safety study conclusion, no physical abnormalities or death of rats, absence of hematological and selected serum biochemistry toxicity, and also there was a severe inflammation at the lung for both the treated and untreated for day 19, and also the control group. So toxicity not caused by EV inflammation because both the groups have the inflammation. In the liver, we can see recovery of inflammation in the treated. So we can say the SCVs improve the liver inflammation. And in kidney, there's some moderate inflammation in the treated group. So there's some effect of the EV in the kidney. And biodistribution, as I mentioned, most of the EVs are accumulated in the spleen. So basically, we can say the high dose SCVs, which is 9 billion particles, is safe for intravenous injection. For efficacy part, we use same SD rats, and we induce the MAT-S syndrome using high fat and high fructose diet for 16 weeks. So then we characterize these animals to make sure these animals show the MAT-S syndrome. Then we group them into 3 different groups of MAT-S, which is MAT-S control, which is given only 0.9 normal saline, which is untreated MAT-S. Then MAT-S LD group, which is given low dose of SCV, which is 3 billion, and MAT-S high dose, which is 9 billion of SCVs. And then the healthy rat, which is also given normal saline as just control for healthy rat. And for the parameters, again, we check the mobility and motility, fasting lipid profile, fasting serum insulin, CRP, leptin, adiponectin, and also the fasting blood glucose and OGTT, blood pressure, and finally, after 90 days, we did the necropsy. So for the metabolic syndrome rat model establishment, as we saw earlier, basically the animals need to have 3 of the 5 class diseases, which is increased waist circumference, increased triglyceride, reduced HDL, increased blood pressure, and increased fasting blood glucose. So we can see here, out of the 25 animals, 1 animal did not show any of these 5 symptoms, so it's excluded from this study. Another 3 shows 3 out of the 5, so it's included, and another 16 have 4 out of the 5 diseases, and 5 rats shows all 5 diseases. So these 24 animals was separated into 3 groups for further treatment with SCV. So these are some treatment, as I mentioned, the treatment plan, low dose 3 billion and high dose is 9 billion, every 3 weeks injection for 9 weeks, and we euthanize at 12 weeks. So for physical monitoring, the control ND group did not show any of the examined morbidity and mortality signs and symptoms. Most of the high-fat, high fructose diet rat showed dyspnea and stress due to poor grooming. So, but they don't have any tumor growth or prolonged or increase in the body temperature. So we can see here basically the MAT-S group. First, the blue line is the control, the healthy animal. The green line is the MAT-S animal untreated. The red line is the MAT-S treated with low dose, and the yellow line is the MAT-S animal treated with high dose. So these three MAT-S animals have a higher body weight, body length, abdominal circumference. Basically, it shows that we successfully induced the MAT-S. However, for the physical monitoring, again, it shows that the injection with SCVs did not have any effect on these parameters, including the abdominal circumference, which is one of the MAT-S characters. So for abdominal circumference, the SCVs did not give any effect. Then on fasting blood glucose, we can see clearly this yellow line and the red line, which is the MAT-S treated with the high dose SCVs and low dose, have significant decrease at 12 weeks. Same for oral glucose tolerance test. We can see there's a reduction in the oral glucose tolerance at 2 hours in the low dose and high dose treated SCVs. For blood pressure, we can also see at 12 weeks there's a reduction, and for systolic pressure, the low dose having a significant difference. For the diastolic pressure, again, both the low dose and high dose of SCV treatment have a significant improvement compared to the non-treated metabolic syndrome animal. For HDL and triglyceride, for the lipoprotein, if you see at 12 weeks, there's no difference, but when we see from the time point 0, which shows the treated animals already having a low HDL. So we compare to timeline from 0 to 12, they show a significant improvement in the HDL in the treated animals. Same for triglyceride. We compare the time-wise from time 0 week to 12 weeks, they show a significant drop in triglyceride level for both high dose and low dose treated SCVs. For insulin and CRP, which actually we want to insulin, if you see the timeline again, they reduce, but it's not significant compared to the untreated. For CRP, the reduction in CRP level was observed until week 6. However, at week 12, there's an increase in the observed control and decrease in the MAT-S group. So you also could not conclude the CRP level from whether treatment have any effect or not. For leptin and adiponectin, the pool WGMSC derived SCVs preparation have no impact on either leptin or adiponectin MAT-S. We can only see all the MAT-S group, the 3 bars here, have an increase in leptin as expected. When we're having MAT syndrome, the leptin is supposed to increase. However, after the treatment, there's no decrease in leptin. For adiponectin, also there's no significant decrease or increase after the SCV injection. For necropsy, in the lungs, there's a sign of recovery for those injected with the WGMSC EVs. So the MSC derived EV also found to have a positive effect on the lung-related injury, inflammation, and ailments. And also we can see here the pool fetal WGMSC EVs preparation has a protective effect on the liver and kidney. So the epidermal white adipose tissue, which is associated with the metabolic syndrome, as the EWAT is highly responsive in visceral depot that can cause inflammation and also enlarge and also dysfunction in the MAT-S syndromes. So we can see here the MET-S syndrome untreated have a bigger, larger size or higher diameter, also shown in the graph here. And when treated with the SCVs, the size of the EWAT decreased significantly. So we can say an increase in the EWAT size was observed in the treated group. I mean, in the MET-S group, there was an increase in the EWAT, and EV treatment reduced the EWAT reduction. So for the conclusion, full human WGMC-derived SCV administered intravenously every 3 weeks significantly improve only 4 out of 5 parameters of MET-S, such as fasting blood glucose, blood pressure, HDL, and also triglyceride. So as I mentioned earlier, there's no improvement in abdominal circumference parameter. Beside this MET-S symptoms, we also found that there's improvement in lung inflammation and hemorrhage with SCV administration, and also in the kidney mineralization, the MET-S animal shows higher kidney mineralization, and when treated with SCV, there's a reduction in kidney mineralization, and also there's a significant reduction in EWAT size with SCV administration and MET-S rats. So general conclusion, I think I've run out of the time. So basically, we can say that the SCV is safe for IV injection with the dose that we used, 9 billion SCVs for 3 weeks, every 3 weeks. And also for efficacy wise, we can say generally it can reduce the MET-S syndrome. However, there's a lot of unknowns, and there's a lot of things behind the mechanism that need to be studied further. So some of the future direction here is to basically study the animal efficacy in the large animal model. Also, we need to produce the SCVs in GMP setting to go for clinical trials. And the latest MySAF guideline also proposed to have some potency testing beside the surface markers as a EV characterization. And we need to study the pharmacokinetic, pharmacodynamic of the SCVs, and also the dose-dependent response of the SCVs. And with all this, we can move to the clinical trials. So the ethics approval. So all these studies have been published in these 3 papers, and we also submitting for the patent, reference, acknowledgement. So this study was funded by industry, Medicals and and also by the university. And it's involved a lot, as I mentioned, a lot of students, staff, and also other agencies in Malaysia. Thank you.
Thank you, Dr. Lokanathan. Any one quick question to Lokanathan?